Let's get started by thanking our wonderful sponsors who make this show possible every week. We can't thank them enough. Many patients come to my practice thinking they have to stop wearing their contact lenses due to dry eye discomfort, but that's not the case. With products and services offered through ABB Optical's dry eye portfolio, like Regenerize Light, a biologic eye drop, I can help patients manage their dry eye symptoms and ship dry eye products directly through ABB, allowing me to have happy, satisfied patients. Interested in learning more? Visit abboptical.com/dry eye. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Vision Edge gives you less eye strain and reduced damage caused by blue light. We like to call Vision Edge sunscreen for the eye. It all starts with your highest level of visual performance, only achievable through scientifically proven Vision Edge.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. Please visit the film's website at openyoureyes2020.com, featuring interviews with more than 50 optometrists from around the country, sharing information on eye care and eye disease. If you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Do you experience irritated, gritty, scratchy, watery, changing vision, or burning eyes? If you do, you may be suffering from dry eyes. Dry eyes can be mild, but dry eyes can also be associated with many systemic diseases and have serious complications. Severe dry eye, diagnosed through an eye exam, many times is the first indication of common systemic and/or autoimmune diseases. Today's guest, Arizona optometrist Dr. Art Epstein, has dedicated his life's work to the treatment and research of dry eye disease. Patients travel from as far as Cairo, Egypt, to the Dry Eye Center of Arizona to seek the expertise of Dr. Epstein. Dr. Epstein is a sought-after speaker, prolific author with hundreds of articles, scientific papers, and book chapters published. He founded and serves as chief medical editor of Optometric Physician and teaches a dry eye masterclass. Dr. Epstein, thank you for joining me today.
Gary, absolutely a pleasure. Thank you for that very, very kind introduction. I'll second your suggestion to view that incredible movie you produced. It's definitely worth watching.
Well, I appreciate that. So let's get into it. So is dry eye an epidemic?
You know, that's an interesting question. When I first relocated from New York, and perhaps the viewers can hear a little bit of that New York accent, to Arizona, I felt that dry eye was certainly more prevalent. But as I delved further into dry eye, which is obviously very common in the dry environment of Arizona, and eventually, soon after opening our practice, limited my practice to dry eye, I began to realize that we're seeing numbers of patients that were unprecedented. We're seeing more and more dry eye than we ever have in the past in younger and younger populations and much greater severity. And I know we're going to talk about a lot of the underlying causes, but certainly the world has changed dramatically. Our bodies weren't designed necessarily for the world we live in today, and as a result, the eyes really take a tremendous beating, and the consequences for many patients are the misery of dry eye.
So what is actually the definition of dry eye?
You've asked a great question. I spend a good part of my day telling patients, I know, Mrs. Smith, you're here because you've been told or you've researched on Google and concluded that you have dry eye, but the problem isn't that your eyes are dry. It's not that you're not making enough tears. The problem is that your tears are not functioning properly, which kind of begs a cascade of questions about what specifically that means. What are tears? What do tears do? Fortunately, we have a good definition. We have a group called the Tear Film and Ocular Surface Society, and every 10 years or so they host a large meeting of experts called the Dry Eye Workshop. And the most recent definition, which is something I don't have memorized, I probably should have it tattooed on on my hand, but essentially incorporates the key concepts of tear dysfunction, failure to maintain homeostasis, which is something we could talk a fair amount about, because I think that's the genesis of a lot of diseases today, and a number of other things, changes in tear film qualities and abilities. But essentially, if you want to distill it down into the simplest form, it's one of the most miserable disorders that we face clinically, because it's chronic, it's progressive, it's persistent, and it's very disruptive to normal function.
Up to 300 systemic diseases could affect the eye, and many times dry eyes can be the initial symptom of a systemic disease, whether, like I said, either autoimmune or any other type of systemic disease. So if you could go over some of the systemic diseases that cause dry eye. Let's start with diabetes.
It's interesting. You kind of hit the nail squarely on the head. We live in an environment where our foods are different than they were at the inception of mankind. Our visual tasking is different. We're certainly seeing tremendous increases in the number of patients that are pre-diabetic, the number of patients that are diabetic. We know that diabetes has a significant impact on a lot of different systems, in some cases, catastrophic impact. On the eyes, it's actually quite interesting. And there's a fair amount of controversy. There's a lot less understood than there is understood, I suspect. But one of the things that diabetes causes is interference with the transmission of nerve signals. Diabetics very often complain of, neuropathy. They have pain. They have loss of sensation in the extremities. The eyes are probably one of the best examples of a networked environment. And what I mean by that is, I'm not talking about vision, which is the conversion of light energy into sight through this incredibly beautiful, complex set of mechanisms and pathways, but I'm talking about just maintaining the ocular surface environment. The ocular surface environment is critically important simply because that's how light enters the eye. So a perfectly smooth refractive surface, which is produced by the tears, is essential to good vision, and certainly a very important factor in selection and evolution. Our ancestors that had good stable tear films were survivors who were able to see predators from a distance and forage for food successfully because they had the advantage of better vision. If we interfere with the control pathways, the sensory pathways, the cornea, for example, is the most heavily innervated tissue in the body. We've known that for years. Some say it's 150 to 300 times the nerve endings that you'd have in skin. Nothing happens in nature by accident. That wasn't like something, I'm just going to give the cornea more nerves than I'm going to give the rest of the body so it can feel a piece of grit more annoyingly. Obviously, there's a reason for that, and some of that is that the input that comes from sensation in and around the eye and its various components is the basis of the control mechanisms that produce a normal stable tear film, that produce the evaporative barrier that maintains the tear film. So diabetics tend to have a lot more problems with dry eye, and probably in large part because there's significant interference with that transmission of information, in both ways, both in terms of sensory and effector or control mechanisms.
Very interesting. I mean, the cornea is the front part of the eye. So for people that are watching, how about autoimmune disease? If we're looking at rheumatoid arthritis or lupus or Sjogren syndrome, why do those people get dry eye, and what percentage do you think of those people do get dry eye?
So this is probably one of the most interesting questions today, and as you know, and hopefully your viewers won't find out during this episode. I tend to be very plain spoken. I say what I think. Sometimes people like it, sometimes people don't. But what you see is pretty much what you're going to get. Inflammation has been implicated in dry eye, for quite some time, really with the genesis of some of the commercially successful anti-inflammatory medications. The reality is not all dry eye is associated with inflammation. Most dry eye, the mundane routine, if you will, not that there is such a thing, but the garden variety forms of dry eye really represent a failure of the systems that maintain normal function from working, and we'll talk probably a little bit about meibomian gland function, because that's a major contributor to function and dysfunction. So for many patients, it's a failure to maintain that balance, that homeostasis, and the eye will compensate by doing different things. It'll make more tears if it needs to compensate for a lack of tears or excessive evaporation, and so on. When we get into systemic disease, rheumatoid arthritis being a great example. Rheumatoid arthritis is a nasty, miserable autoimmune disease where the body attacks itself. Typically it attacks joints in a characteristic way. Rheumatologists certainly are very familiar with that disorder. Again, like many things in medicine, it's not fully understood, but we have certainly a better idea of what it is and how it's managed now than we have in the past. And even though it typically will affect the joints, there are some patients where the impact on the joints, the skeletal system, is relatively minor, but for some reason, because inflammation does what inflammation wants, it will attack the eye itself, and sometimes the cornea, which is the clear dome that you referred to before, that is at the front of the eye, becomes so horribly attacked that it begins to decompensate. And we see, loss of structure, what we call punctate keratitis, or surface damage, surface staining, and this can be extremely painful, very disruptive to vision, can lead to progressive inflammation. So inflammation begets inflammation, and I've had patients, as I think back over my career, the patients where I've been afraid, and I believe in taking it home with you. I don't, some people say, well, you should always leave it in the office. And it's probably healthier to do that, but that's not me. But the patients I worry most about, and that group would include patients with rheumatoid arthritis. I have one in particular that I literally nursed back to function. In fact, I, see her now every 3 months. I used to see her every other day for a while, and then every week. And it's because rheumatoid arthritis is a nasty condition that can attack the eye and provoke more inflammation locally, as well as this systemic inflammation. Sjogren syndrome is another interesting one that you mentioned, and that's a disorder that was first described by Sjogren, who was a physician in the 1920s and 30s, who was the first to really recognize dry eye as an entity. The dry eye that he was describing was inflammatory dry eye. And again, that's an inflammatory autoimmune disease that happens to attack the moisture-producing glands in the body, which involves both the eye, and the eye is dry in that situation, the mouth, and so on, even skin and other areas. And that very, very difficult to treat. Lupus, again, another autoimmune disease that affects a number of different structures, a great masquerader in many ways, but can sometimes just affect the eye in and of itself, even though it can affect the rest of the body. And those patients need to be treated aggressively with anti-inflammatories, because inflammation needs to be controlled. In contrast to the inflammation that occurs as part of the body trying to fix a problem that it can't manage locally through control of functional mechanisms, it can invoke inflammation. That's generally mild compared to the autoimmune inflammation that we see in dry eye.
What's interesting in thyroid disease, whether we're talking about Hashimoto's or we're talking about Graves' disease, dry eyes are common in people with thyroid disease, thyroid eye disease. This showing that there may be a hormonal component. And if you
Yes.
could speak to that.
Yeah, it's interesting. Some of these diseases are very, very complex, and the complexity is from an academic, and a clinical perspective, I think fascinating. But unfortunately for patients, fascinating sometimes means, absolutely miserable. So thyroid disease can alter the exposure of the eye to the environment. And, one of the things that the eye needs to do is maintain control over the amount of exposure, because that in turn controls the amount of evaporation and the interface between the tears and the outside environment. Interestingly enough, the tear film, one of its main functions is to serve as a normal environmental barrier against incursion from the outside. The same way the skin is essentially a wetsuit that keeps us from dehydrating in the miserably dry weather in Arizona. So thyroid disease, number one, can affect that. Thyroid disease can also invoke inflammation. And when we talk about inflammation, very often the areas of attack not only are the surface, but also the lacrimal glands, the glands that produce the aqueous or water component of the tears. So these patients often experience dry eye because of disruption of normal architecture and normal topography, because their eyes are larger and more exposed, more prominent, but also because less tears are produced. And those patients, when they're managed properly systemically, very often those diseases are easier to control. At least their eye manifestations are easier to control. So it's one area where optometry and primary care medicine, endocrinology, and so on can interface very, very well. Dentistry as well in Sjogren's disease, for example, where a multidisciplinary approach really makes a big difference.
In Graves, a lot of times people's eyes will look like they're popping out, something we call proptosis, probably about 50% they estimate. And that could be a problem. And like you said, that's something that we want to make sure is treated systemically. But when people's eyes are like that, what could we do to help them because they're so uncomfortable?
Well, that's a very, very good question, because nothing is ever simple. One of the things you learn as you become more experienced clinically is that sometimes the simple is actually very complex, and the complex actually is an opportunity to learn. In fact, one of my most common statements to patients, if I understand what's going on with you and it's very clear to me, and I have a good grasp on everything, it's going to be easy to address your problems, but I'm not going to learn very much in the process. If you really confuse me and things just don't make sense, I'm still going to address your problems because I don't really have a choice. That's what I do, but I'm going to learn a lot in the process of doing it. So in a case where you have a significant amount of proptosis, you have to attempt as best you can to reestablish the normal barriers. So you have to go back to basics. How does the eye maintain structural integrity, at least relative to the outside environment? Well, it's the tear film. How does the tear film work? Tear film is actually very, very complex. And the tear film is a structure like any structure that your listeners would be familiar with, like a house. Tear film has a foundation. The tear film has a middle space, an intermediate space, like a living space in a house. And the tear film has a roof, if you will. And in the case of a house, the roof keeps moisture out, which is a very important function for a roof, and also gives the entire house structure with beams and joists and so on. In the case of the tear film, the roof is made of lipids. Lipids are produced by glands called Meibomian glands, which are often dysfunctional due to modern times and visual tasking and things we can talk about in more detail. But if you can restore this normal structure, then even in a situation where the eye is overexposed because it's bulging out, you're way ahead of the game. In addition to that, you may need to supplement the tears. We use a variety of things. I've recently discovered a European product called Sicca Forte, Sicca-Forte, which is a carbomer-based gel, which remarkably doesn't cause a lot of blurring, but it actually is a very effective mucin substitute. Basically, it bulks up the tears. so that it makes the tears more sustainable and actually improves patient comfort, and it helps them stretch. It makes them more elastic. So again, in an eye that's bigger and more prominent, it helps as well. Sometimes in more advanced cases, we have to create an artificial barrier. Sometimes if it's not a very, very profound amount of exposure, we can use a soft contact lens. Sometimes we have to use a larger rigid lens like a scleral lens, which is a shell that creates a solid barrier, if you will, maintaining moisture. Sometimes we can use moisture goggles. We can use goggles that actually have padding around it to reduce evaporation. But most importantly, in a patient like that, you really want to get their systemic disease controlled, because most often many of the problems will minimize once that occurs.
So about 18 million people have sleep apnea, and they're more likely to have floppy eyelid syndrome, more common in males than females. They have lower blood oxygen levels. Why do they have dry eyes, and what have you seen with apnea patients?
You know, that's also a great question. You know, you're hitting them out of the park with really good questions. And some of these are somewhat esoteric for many of our colleagues that, you know, don't have the benefit of, you know, having patients that have generally been, you know, to several offices without relief. And, you know, I call our practice jokingly the cradle of misery in Phoenix, because, you know, we get these patients that have really suffered and really not found resolution. Sleep apnea is a miserable, but unfortunately very, very common disorder. We see it in patients that tend to be, you know, somewhat overweight. We see it more commonly, as you mentioned, you know, there's a sex difference, you know, in males more often. It's also associated with conditions like, you know, keratoconus, which in and of itself can change the shape of the eye, which can lead to dry eye. But what's actually happening is the lids need to close reasonably well. If the tear film is stable, as say it would be in an infant, the eyes can stay somewhat open without any problem. So, you know, very often you'll hear parents complain or ask questions to pediatricians or their optometrists or ophthalmologists. Oh my God, my baby's sleeping with their eyes open. They look possessed. You know, is there a problem? And the answer is no, generally not. You know, they recover from it. When a patient has exposure caused by a lack of proper lid closure and their tear film is unstable, what ends up happening is the eye desiccates or the eye dries out. Typically in a classical pattern, we see damage, you know, at the area where the lid and the upper and lower lid would normally be closed, but remain somewhat open. It also depends on whether or not the eye rolls up naturally, which it typically does in normal patients protectively during sleep. But when you have a patient who has floppy eyelid syndrome, the anatomy that keeps the eye closed is bad. So they have a tremendous amount of difficulty achieving you know, good, stable lid closure throughout the night. In addition, often the lids will open somewhat and they will get abrasions on, you know, pillow corners and things like that. So those patients have a much higher proportion of what we would put in the bucket of dry eye because of just a lack of normal anatomy and function of the lids, which are important. And there's one other quick thing that I'll mention. The lids are the most effective pumping mechanism we have for some of the elements that maintain a functional stable tear film. And when you have essentially floppy, you know, really not effective lid function, you probably reduce Meibomian gland clearance and Meibomian gland function, which contributes to that as well.
And the patient can lay in bed and their head could hit the pillow and their eyelid could just flip up and they could wind up scratching the front of their eye.
Yeah, which they do, and actually sometimes they'll initially present as an emergency, you know, with an abrasion that they'll get in the middle of the night. Sometimes those patients will come in and say, you know, when I wake up in the morning, I literally have to pry my eyes open, you know, using my fingers, you know, because my eyes are so dry and sticky that they won't open on their own. It's just too painful for me to do that. I actually have to, you know, kind of pry them open and, you know, hope for tears to start forming.
At Allergan Eye Care, their goal is to protect and preserve vision. It's not just what they do, but it's who they are. They've been creating innovative products and services for providers and patients for over 70 years, and they continue to push the boundaries of what's possible in eye care each and every day.
Macular degeneration is a leading cause of vision loss, with 15% of Americans being at risk or already affected. Scientific evidence proves that by using mesozeaxanthin, lutein, and zeaxanthin together replenishes the macular pigment and promotes healthier vision. This formula comes in only one product, MacuHealth.
How about for our patients who are using a CPAP machine and that's drying out their eye?
Yeah, yeah. CPAPs are the devil's work, for dry eye patients. It also depends on the generation and how it's fitted. If it's fitted properly and it's a newer generation CPAP, generally we have less problems. But CPAPs will often not seal properly, and if you have floppy eyelid syndrome, which is very common in that group, as you astutely noted, you end up with air blowing over the eye in a plane, drying. And what I mean by plane, plane this way, not flying plane. It just dries them out terribly, and it can actually do a significant amount of damage. A company called iEco makes a goggle, a silicone goggle, which conforms nicely to the shape of the eye and actually has little extended flaps that you can put the CPAP over so that it blows air over the clothes, or actually blows air over the goggle instead of blowing it into the eye. And that works well for some patients.
Allergies and asthma patients are at greater risk for dry eye. They complain of dry eye and their medications that they take. If you could go over that a little bit.
Yeah, no, that's spot on. First of all, allergy, is the gift that keeps on giving with dry eye, and essentially what I mean, by that is one of the first things we learned years and years ago, before we had really good allergy medications, is to dilute the tear film, contents with artificial tears. So it was like a first line allergy medication, prior to effective pharmaceuticals. So the volume of the tears is an important protective factor against allergens, which can cause reactions that are somewhat dependent on the concentration of the allergen. So if you have dry eye and you're allergic, it's going to be worse because you don't really have the protective ability of a tear film and the drainage of the tear film, a functional tear film to wash that away. In addition, patients who have asthma also tend to have significant amounts of allergy as well. Plus, as you know, the medications often are drying, so you have less production of the aqueous, or the watery component of the tears, which again contributes cyclically by causing even more drying. So kind of spirals out of control. Fortunately, there are newer medications, topical medications that work well for many of these allergy patients that don't produce drying. It's really the systemic medications, especially the older generation antihistamines, that will produce significant drying. So those patients can generally be managed well, although they certainly have a raft of other problems.
Other medications that could cause dry eye, such as hormones, estrogen, progesterone, some of the hypertension medications like hydrochlorothiazide. You could talk a little bit about that. The retinoids.
Yeah, I mean, we literally, we have lists of medications that cause dry eye, and the medications today are so ubiquitous. If you go back a generation or two, we had patients that really were in better shape. They were leaner. The body fat was much lower, so they were tended to be healthier. And then I remember you take a history, and an elderly patient might have one or two medications, maybe for hypertension or something like that. Today, if I see someone who's over 50 and I don't have to scroll through the list of medications, I'm actually surprised. And I think most of us and many of the primary care physicians don't realize that many of these things produce a significant amount of drying potential. For example, antidepressants and some of the psychoactive drugs can produce significant drying. And in those cases, I think what's often overlooked is the psychological impact of dry eye in and of itself. We routinely have patients who, when they sense that relief is possible, they're so severely impacted, they break down in tears. They literally will start sobbing and crying because it's such an emotional thing for them. And many of the routine medications that we take, from antihistamines, as you mentioned, the hypertension medications, diuretics, certainly, and there's other medications I'm not even thinking of right now that, produce drying. One of the things that I think every patient should do, because a patient today has to be their own advocate, is when they get a new medication, there's a package insert. And it makes sense to, I know it doesn't make for pleasant reading. It's not a novel, but it does make sense to read about the potential interactions and the potential complications that can occur, so that if they suddenly develop dry eye symptoms, they can then either return to their optometrist or ophthalmologist or their primary care physician or the prescriber and say, my eyes have, started to get really dry since that medication that you prescribed, kicked in, and I started, when I started taking it, is there something else? We see that, we see medication effects. I had a patient not long ago, probably 3 or 4 months ago, who had amiodarone toxicity. It's a drug used for cardiac problems. It hasn't been used a lot in years, but he happened to be on it, and he had this verticillata, this whirl-like pattern in his cornea, which indicated toxicity, which is problematic. So, of course, I sent him back to his cardiologist, who was familiar with the complication. And that's an extreme example and not dry eye related, but dry eye can be nasty, and if it's already somewhat prevalent, somewhat present in the patient, making it worse really is not a good thing.
Even osteoporosis and migraines sufferers are associated with dry eyes.
Yeah, I think it's interesting that you say that. Yeah, yes, it's true. But once you start getting into, I think this wastebasket of everything that's associated with dry eye, migraine sufferers, probably there's a neurologic aspect to it, because obviously migraines are somewhat complicated from a neurological point of view. But there are many things. I mean, literally almost anything that we do in modern times, can produce dry eye. There's some things not, and so I think patients need to ask questions. I think doctors need to be familiar with it. I would venture to say that some of our colleagues are not familiar with some of these more esoteric aspects of dry eye, and some get overly lost in the sauce, if you will, because you have to really think about what can I do when you're looking at the patient that will make a difference in this patient's life. What do I need to do that will make them less symptomatic, make them much more comfortable, and make their life better. And I can't take away their migraines, but I can stabilize their tear film. Same thing with Sjogren's. Many years ago, we talked about Sjogren's just a minute ago. It's a nasty, miserable disease. I had a patient that suffered from Sjogren's for over 20 years. It really had significant negative impact on her life. She came in with wraparound glasses. Her face was a mask of pain. And I realized very quickly I couldn't make more tears. Sjogren's is a disease of lack of tears, but I could stabilize the tears and make the tears more effective, which I was able to do. Last I saw her was, 2 or 3 years ago. She hasn't been back, and I know the reason why is because she's doing fine. The last 2 times I saw her, she was not wearing her wraparound glasses, and she was out playing golf. And she had her life back because I came up with a strategy for managing that. So to your point, lots of things can be associated with dry eye, but from a clinician's point of view, as someone managing it, you have to realize what you can do to have positive impact on their clinical situation.
One of the worst is chemo.
Oh, yeah. In fact, I'm really glad you mentioned it because, I think anybody who does what we do develops emotional ties to patients. Those emotional ties are very strong. And I think a lot of patients don't understand just, how connected we are to them. Several years ago, a lovely woman came in. She had just finished a course of chemo for metastatic breast cancer, and she was in utter misery. I mean, she was just in just horrible agony. Very bright woman, owned a business, successful, large business, and was almost incapacitated. she had virtually no Meibomian glands. Chemotherapy, not every chemo variation, but many forms of chemo will destroy the Meibomian glands, which are essential as manufacturing facilities for the lipids that create a stable tear structure. They're manufacturing sites and storage tanks, if you will, for lipids that stabilize the tears. And what was interesting about her is that her tear film was extremely stable, which made absolutely no sense. I'm looking at her lack of glands. She's absolutely miserable. Her tear film is stable as a rock. I mean, it looked like a perfectly normal tear film, which so that made no sense. And then when I started examining her using a slit lamp microscope, her tear film looked like gelatin. I mean, the tear film was so viscous that it was, it was incredible. I mean, I'd never seen a thicker tear film. And that led to a series of, essentially epiphanies where I began to better understand what was happening. And this was an example of what I see now all the time because I'm looking for it and I recognize it. The eye was trying to right its ship. It was adjusting the manufacture of gel-forming mucins to compensate for the lack of lipids. And this is a perfect example of what we talked about before, homeostasis, this need of the body to maintain balance. So, in her case, she's doing well now. We're using a lot of advanced technology, IPL, and a number of other things, and she functions. She's, we've given her life back. I see her all the time, and it's one of it's one of those great things that, it's one of the great things that we can do where we can make that level of difference in a patient's life, especially someone who has faced such adversity and come through it. So chemo can be very, very nasty when it comes to dry eye.
Close to 30% of patients with dry eye have depression. In fact, there's a famous broadcaster that's been in the news, Shannon Breen, who supposedly considered suicide because of her misery from dry eye.
Yeah, in fact, I happen to like her as a newscaster. She's a straight shooter, no political commentary meant, but I just happen to like her as a newscaster. And I was actually shocked to see, you never think of it. She's this, intelligent, lovely, competent presenter. And you would think, she's just perfect. She has an idyllic life. She's, a famous, famous person. And I was actually quite shocked to learn that she suffered from severe dry eye. She also suffered from a related condition called recurrent corneal erosion syndrome, which was one of the major factors that I think was driving some of the depression, because that's one of these incredibly nasty, mean-spirited conditions where you go to sleep at night and you don't know if you're going to be woken up feeling like someone just jabbed you in the eye with a sharp poker. And finally, she found someone who figured that out and is able to manage her dry eye. But she was very upfront and transparent about the impact that this had on her life. And we see this all the time. As I mentioned, patients break down in tears all the time. There's a sense of hopelessness. It's hard to imagine, if you don't suffer from dry eye, just how debilitating it can be. There is no relief. There's no escape. It's agonizing. I look at dry eye in three buckets: discomfort, grittiness, burning, irritation. Similar, somatic, discomfort elements. There's visual instability where the patients, don't have a stable, visual perspective. They can't look at a computer without, blinking and, struggling to focus. And then there's the aesthetic aspect of it, where the patients look like they haven't slept in weeks, and this continues to mount, and it's chronic and it's progressive. And many of our colleagues just aren't that in tune with this, and they just hand out artificial tears, which basically do nothing, or maybe prescribe a medication that may not be helpful, or put in punctal plugs, which I don't think do very much. And the patient begins a cycle of, increasing helplessness, because they're going to someone who, should be helping and isn't helping in the way they need. And eventually they hopefully find someone who can. But we often see, not only depression, but we see how it affects the entire family. We see, husbands and wives coming along with them, and you can just see how disruptive this is. And the fact that it's dry eye, and everyone says, "Oh, dry eye, it's, stop complaining, just take some of these drops and you'll be fine." it kind of minimizes something that's not minimal for them. So it's, yeah, it's a big, big issue.
You brought up that cancer patient who was producing tears that were like gelatin. Talk about the concept of homeostasis. I know that's something that you feel is very important in the treatment and the whole concept of dry eyes, or the cause of dry eye.
Right. That's homeostasis, Kerry, is a new concept. Uh, my epiphany came before the definition, and at first I didn't realize that the definition was, embraced my epiphany. And we can thank Kelly Nichols, who's a colleague and the dean of optometry at UAB in Alabama, who's a brilliant researcher, and she was in charge of the definitions committee for the DEWS II report. And I know she was instrumental in adding the concept of failure to maintain homeostasis. Homeostasis was first described in the 1930s by a physician from Harvard named Walter Cannon in a book called Wisdom of the Body, although I think the concept had been around, but he was the first to really focus on it. And in a simplistic way, homeostasis essentially describes what happens if you go out and to very cold weather without warm clothing. The blood shunts away from the periphery and moves to the core so that the heart and lungs can continue to function. And if you're still cold, you'll start to shiver to generate heat because the muscles, as they start to work, they'll produce heat. And the exact opposite in the summer in Arizona, you'll start to flush as your vessels dilate to bleed off heat, and you'll start to sweat to create evaporative cooling. In the eye, it's much more complex than that. And I've taken homeostasis essentially means that the eye is under a exquisitely complex network of control and sensory, I guess not procedures, but sensory functions, so that everything remains in balance. So the concept of homeostasis in my patient, there are cells on the surface of the eye called goblet cells, and goblet cells produce mucins, which can produce gels. There are two different types of mucins. There's transmembrane mucins, which help anchor the tear film, create a foundation, and there's gel-forming mucins, which create cushions and essentially viscosity to the tear film. Normally, they are bit players in the overall tear film dynamic. In this particular case, because this young woman wasn't able to make enough lipid to maintain a stable tear film, the brain figured out that things weren't working as they needed to, and invoked the goblet cells to produce additional mucins. So, again, it created that balance. As I kind of look at it, there is a dimensionality to how the eye functions, and the fact that every single system that maintains a tear film interacts with every other system, and I consider the third dimension. Most of us work in the first dimension, which is, oh, your eye is dry, here's a bottle of artificial tears. Some of us work in two dimensions. Oh, your eye is dry, and I'm going to give you some tears. I'm going to give you an anti-inflammatory. I'm going to do something else. And I recognize that there's constant change depending on the environment, because when you go to Tampa, you don't have such a bad dry eye. When you go to, come back to Phoenix, your dry eye gets worse. The third dimension is that not only is all of that happening, but everything that happens is interacting with everything else, which makes for this exquisitely complex and really beautifully elegant system of maintaining what is probably the single most important sense for survival in humans. So that's the long story of homeostasis.
So you brought this up. Why do we have a tear film?
That's what God only knows. But
You gave it.
It's so funny. I tell patients, if let's say, if you believe in God, which is fine. I don't get into religious issues, because you never know. I said, if you believe in God, and God was looking for an engineer, and he said, hey, it's you're the engineer, make an eye, create an eye. So, if it was me and I was an engineer, I'd say, okay, I'm just going to make a dry eye. Why would I want to go to the trouble of making tears and, producing them and, and making them anti-infective and creating viscosity and preventing evaporation and countering gravity. And I could go on for a half an hour with all the things that tears have to do. But the problem is that doesn't work because um, tears create a perfectly smooth refractive surface. I tell patients it's the only solution to a fundamental problem of all mammals and in humans in particular, because we're so high in the evolutionary change. Without tears, we wouldn't be able to see well enough to survive. We wouldn't find food. We wouldn't recognize friend from foe, dinosaur from pet. So tears, like a reflecting pool, create this perfectly smooth surface. And secondarily, once you commit to a wet environment, tears also have to serve the functions that we alluded to before, separate, this delicate, complex surface from the outside environment, which is ever changing and often very, very harsh. So, we have tears. Nothing happens by accident. If there's one example, one area where that's absolutely true. We don't end up with a million, billion corneal nerves for no reason. Any more than we ended up with the tear foam, because neither was easy to do. There's a reason for it.
What do you think the main symptoms of dry eye?
Well, I mentioned before, I put it into three buckets. The discomfort, the irritation, the burning, the grittiness, that sometimes excessive tearing, because that kind of goes along, with that. It's just a variation of it. And the other one is blurry vision, and the other one is redness and aesthetic or cosmetic issues. The majority of patients I see complain of discomfort. There's usually a little bit of column A, column B, column C. Very few people come in with white, beautiful, clear-looking eyes and have profound dry eye. But I would say, the majority of patients, probably, 75 to 85% of the patients that I see come in complaining of the discomfort elements, and probably about 20% of them excessive tearing. Reason why they tear excessively, which seems completely opposite to what you would expect, is because reflex tearing kicks in. We have this secondary tearing system which washes things away, because nature figured out that when mankind, womankind first roamed the earth, we didn't have nail clippers or nail files or manicurists or soaps and and hand washing. So if you put your finger in your eye, you'd mess your cornea up and end up losing the eye, and that would be it for you. So we got created with a reflex tearing system to wash things away, and everyone's familiar with it because everyone's tasted their tears. Whether maybe they were a baby when they cried or whatever, it's salt water. In contrast to the tears that I mentioned before, the basal tears, which are structural in nature. So definitely discomfort with the leading presentation that we see.
It's always interesting when a patient is tearing a lot and we tell them they have dry eyes. They look very befuddled.
Yeah, it's funny. I always prepare. I go, I know you're going to think this is kind of crazy, but you have dry eye. And let me tell you, some of those patients are among the most badly impacted. I had a gentleman, really nice guy, a salesman who did a tremendous amount of flying back in the day when we could fly. And he came in with a golf rig, and I don't play golf myself. I have, and that's why I don't, because I'm so bad at it. But I spare my friends my golfing skills. But I remember winning a golf rag as a consolation prize for the worst golfer of the day. And I thought, boy, this is a really long rag. This poor guy walked in with a golf rag that was soaked with tears, which was gross, to be honest with you. It was, he literally traveled around mopping his eyes continuously. Thankfully, we were able to straighten him out pretty quickly, and then he moved away, and I haven't seen him in quite a while. But his dry eye was actually a wet eye.
What do you think the main causes of dry eye are?
Oh, that's interesting. The main causes of dry eye, I think, the main causes of dry eye you could blame on Wozniak and Jobs. I think I blame those two guys because we forget that not all that long ago, no one read. In fact, if you think back to the Westerns that, you may have enjoyed as much as I did when I was a kid, you'd buy the landowner or the land purchaser, I should say, it's like, put your mark here because, there's illiterate, you make an X. And, back in those days, everything was, word, you trust someone on their word and I guess on their mark. And my own grandfather, much to his embarrassment at times, was illiterate. He grew up in a horrible environment in Romania and just never was educated. And my grandmother read, thankfully, but my parents obviously did, or not obviously, but they did. My father, graduated from college and was not much of a reader. My mom was an avid reader. She read, constantly. But reading is also very different. My brother was a bookworm, and he would get yelled at. Put the book down. Go get fresh air. Which, if you grew up in the Bronx, was another way of your parents saying, we're tired of seeing you, go get kidnapped. So, get out, get some fresh air, go find some friends. And, so reading was, for me, I was a science fiction, addict as as a young kid, but I put the book down, and TV was a 7-inch screen and a beautiful mahogany cabinet that, we gathered around and used our imagination on. In 1977, the Apple II was introduced. It was the first commercial computer on the market. There were others, there were breadboard computers and things like that. 1982 was the IBM PC. It took a decade for it to begin to propagate into offices, the creation of software like VisiCalc for the Apple and Lotus 123, maybe bringing back old memories, and people started using it in offices, and then word processors became fairly common, and then it became household. About 12, 13 years ago, the iPhone was introduced, and suddenly computers were now traveling with everyone. I haven't been in a restaurant in a year, but back in my youth when I would go to restaurants and be able to interact with people, you'd look around and you'd see married couples would be texting and reading news as they were having their dinner. So we spend so much time in front of computers and inputting information. The brain is very, very powerful. It doesn't like the interference of the blink. The blink is a natural element in the overall function of the system that maintains the eye's integrity and the tear film in particular, its function and integrity. And inhibited blinking, among other factors, dietary changes as well. The fact that we don't take in, omega-3s at the level we really need them, EPA, in my estimation, importantly, has all contributed, and it's kind of crescendo today with, young kids who spend their lives in front of computers and iPhones and gamers, barely completing a blink. The blink needs to complete for lipid to be released effectively. And what ends up happening is you end up with a tear film that just isn't doing what it needs to do. And the patient gets worse and worse and more symptomatic. And here we are today.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.